predictors of clinical predictors of long-term outcome. And so today what I'll try to focus will be on the neuroimaging bit. And let me see the neuroimaging, how neuroimaging and how will it help to predict the long-term outcomes. So we'll start a little bit initially about the cranial ultrasound, and then we'll move towards the MRI with the MRS if required. And then we'll also talk a little bit about the amplitude integrated EEG, which is the what we call as cerebral function monitoring, because that will be a surrogate marker than compared to an EEG. Finally, just brief word on ophthalmology and audiology assessments. So this is what predominantly we'll try to cover today. So we'll take at least half an hour to 40 minutes, and then after that, if there are any questions, then we will take it forward from there. Okay, so here we in the NICU cranial ultrasound scan is one of the point of care tool, and it is very helpful if you guys can start doing the cranial ultrasound. There are multiple courses which will do which will teach you how to do the cranial ultrasound scan. It is not a rocket science. It's very easy to do the cranial ultrasound scan. Compared to echocardiogram, cranial ultrasound is very easy because the brain is not moving. So it's a stagnant image. So it's very easy to sweep through. Whereas an echo, because the heart is pumping, it's a mobile organ. So doing an echo while a mobile organ is a bit difficult. But it's not impossible. So, but start with cranial ultrasound scan, and it's very helpful to predict long-term things. So, cranial ultrasound scan can be used for preterms and term babies. Okay, preterm babies. I was talking earlier on. It is the IVH and the PVL, whereas the term babies we are predominantly looking at the HIE. And so today what I'll try to focus is on the term babies, because I don't want to confuse them at the same day. So today I'll talk about the cranial ultrasound scan of a term baby, because that is what predominantly you will start seeing. So, and the term baby, the main thing is HIE. So today we'll talk about the cranial ultrasound scan for a term baby with HIE. Next week, when I'll talk about the cranial ultrasound scan for a preterm baby. Okay, so that will be the two differentiation. So let's go with the term baby. So main thing here is if you're looking for HIE, so that is the main thing. So you want to rule out any non-asphyxial causes of HIE, because main thing what you'll have to do is that you look for any congenital malformations of the brain. If there's an intra-intellectual hemorrhage, it's very rare in a term baby, but you want to rule that out, because this can all happen intrauterine. The child might have had a preterm and had a bleed, and then as a result the baby will have a porencephalic cyst. So you want to rule out all these congenital malformations before you look for HIE. The main thing what you look for in a term baby is you look for cerebral edema. So I'll show you some images on cerebral edema, because this is a classical marker for HIE. So we want to rule out cerebral edema. And then the second thing which you want to look for is the deep gray matter injuries, which is basically the basal ganglia and the thalamus injury. That is what you look for. So significant basal ganglia and thalamic changes are the main reason which you look for long-term motor deficits. So when you want to predict long-term outcomes, you are looking for what we call as the BGT lesions. BG is basal ganglia and T is thalamus. So BGT lesions are the main things which are associated with long-term motor outcomes. So when you do an ultrasound scan and if you see a BGT lesion, then you will be at heightened awareness to see this child, start physiotherapy and stuff like that. So that is the main thing. So look for cerebral edema and look for the BGT lesions. These are the only two things which you want to look for in the HIE babies, so that you can start predicting the long-term outcome. Right. So how does cerebral edema look? So so if you see this image on this side, you will start seeing this sulci and gyri. This is the sulci and gyri. So this is the interhemisphere. You will see some sulci and gyri. When you come here, you don't see any sulci and gyri. So absence of sulci and gyri, these are the main thing which you look for in cerebral edema. In cerebral edema, the edema is so much that you lose the sulci and gyri. So it's completely like a very mashed section. There is no differentiation. Whereas here you can see that is the interhemisphere. You can see a little bit of sulci and gyri going on here and stuff. So this is what we'll call sulci and gyri, but you don't see it. And so this is the first thing which you see, that this child has cerebral edema. So although you have anterior fontanelle, as a result, you don't need to send this child for a neurosurgical referral or anything. But at this point of time, that is not a good outcome. That if you have cerebral edema, that means the brain is swollen. So you will have some amount of compression effect. So that's what you look for in the first thing. The second thing I told you is the BGT lesion. BGT lesion is that basically your basal ganglia and the thalamus will come here in this area. And as you can see, you are seeing a increased echogenicity. So here you see it's just dark. You don't have any, this one has cerebral edema, but there's no BGT lesions. Whereas here, this child has got no cerebral edema, but you can see some increased intensity happening from the basal ganglia area. So this is the crude way. So ultrasound is just a screener. It is not sort of the diagnostic, because whenever you see any images on ultrasound, it should you should suspect that this child might have some problem, and you want to send this child for MRI. So that is how you will. You can't go predict long-term outcomes on ultrasound. So what it will tell is that if you see cerebral edema, if you see BGT lesions on the ultrasound, you think that there is a good chance that this child will have long-term outcome. If parents ask you, if you go counsel parents on ultrasound, not a good idea, because you can't absolutely predict. You can only say, I'm seeing some abnormal changes on the cranial ultrasound scan. I need some more information, so I'm going to subject this child for an MRI. That is the bottom line of the ultrasound. So ultrasound is just a screener. So you're looking for cerebral edema, and you're looking for the increased signal coming from the BGT lesions. That's all. Now, the third thing which you have to do is something called as a resistive index. So these are the only three things you should do. Resistive index, this will all, as I told, all this will be taught in a course. But what you're trying to do is that you're going to go to a coronal view. See, you can see, appreciate the sulci and gyri so beautifully here. So that is sulci and gyri. But you'll go to the sagittal view now. So this is the sagittal view. So you're cutting the brain exactly one half. So you're looking at the midline. So this probably will be the corpus callosum. Yeah, that will be a corpus callosum. And when you get to that one, when you put a Doppler, color Doppler, you put color Doppler, you will start seeing the blood flowing through the MCA, or sometimes it will come through the ACA, the middle cerebral artery. You will see at the middle cerebral artery, you will put a pulse wave. A pulse wave is the wave. When you put color, you can look at the what is the flow through that. So this will be the blood flow going through the systole, and this is the blood flow which is going through. So this is the blood flow which is already going through the diastole. Okay, that's a low. But during a systole, the blood will peak. So this is what we call as the systole and the diastole. Okay. Now you need to find what is the difference between systole and diastole. So that will give you something called as a resistive index, RI. Okay. And what you try to do is that you take the, it's automatically calculated by the machine. You can see here the RI is given as 0.49. Okay. But how will you calculate is that it is the difference of systole minus diastole, the whole divided by systole. So for example, let's give an rough idea. Here it is like 60 centimeters per second. The systole is running at 60 centimeters per second, and perhaps the diastole is around 40 for ease of calculation. So 60 minus 40 is 20. The whole divided by the systole. So that is 20 divided by 60 again. So that is basically 1/3. So 1/3 is about 0.45, isn't it? One-fifth, sorry, half is 0.5. So 1/3 will be around like 33 or 34%, something like that. So the value here it's coming as 0.49. So that is what they are giving, which means any resistive index below 0.55, that is a number which you need to remember. Anything below 0.55 is associated with poor outcomes. Okay, so there is no major thing which you have to worry here with ultrasound scan. This is a very quick and easy tool for every HIE case you have to do, and you have to find out whether it's what is the resistive index. And the sensitivity of this is 99%. That means true positives you identify are 99%. Specificity, true negatives are 81%, but very high sensitive. So this is one thing which you will have to do for all HIEs, and to find out if the RI is below 0.5. Okay, so that's all cranial ultrasound scan is about. You attend our course and you will find out. But in HIE, you will be looking only for three things. One is for cerebral edema, where you don't see this nice sulci and gyri. Number two, you're looking for increased sections from the BGT lesions. This is all the coronal view. And in the sagittal view, you look for the resistive index. If you do these three things, you have got most of the details what you want. In the next class, we will talk about the IVH, because IVH and PVL, it's a separate lecture on its own. And I didn't want to waste 1 hour on that one, because every course will teach you how to identify IVH, what is the grades of IVH and stuff like that. So next week, I'll try to just briefly go through the grades, but attending a course will be very helpful. Okay, so that's about the cranial ultrasound scan. You have any doubts? I'll give you 10-15 seconds. If you can message, that will be good. As I'll wait, I'll just summarize. So HIV is something which will keep evolving. It is not stagnant. So it will keep evolving over time. And hence prediction on ultrasound is not reliable. That's why we say don't rely on ultrasound. Always look for a MRI. If there is a significant abnormality present on day 1, then outcome is usually bad, because we think, okay, there's something wrong. We have to go forward and see whichever it is. Cranial ultrasounds can have a very good correlation with MRI. But as I told, MRI is more definitive. Once you have MRI, you can discuss the outcome with parents. But use cranial ultrasound scan just as a screening tool. So don't counsel based on the cranial ultrasound scan. Okay, I take there are no questions because I don't see anything in the chat either. Okay, if there are no questions, then let's move to the next big bit. So the next big bit is the MRI and MRS. Now, these are all done usually under sedation, or if needed, you have to do under anesthesia. So that means child will be intubated. But this will always be reported by a neuroradiologist. So in that way, you will have good reporting. So you don't need to, because ultrasound scans, you do it. So you need to know, because the ultrasound scan, unless you ask a radiologist to do it, then you get a report. But ultrasound scan, that middle of the night and something you want, it's a point of care. So that's why ultrasound scan, you need to know completely in and out. MRI, MRS, you will have a neuroradiologist who will report it. But just to complete it, as for if you're looking for HIE, what you need to look for, because this is very simple. Because my main research is in HIE, so I usually read all MRIs or things only for HIE. So as I told, in an acute insult, because this is a perinatal event, you get injury to the deep gray matter, and the main thing is the BGT. Okay. Sometimes you get the watershed areas. Watershed areas are where you got high blood supply, and typically around the ventricle areas, you will see watershed areas. Is also predominantly seen in the partial insult. This one is a complete insult. This is a partial insult. So you will see some amount of injury in the watershed areas. Now, very simple. You remember that ultrasound scan where I was showing you. So I just showed you increased echogenicity happening from the BGT lesion. The same view. Now this is the same view. Now you're going to the coronal view of the same ultrasound scan. Now you can see the two ventricles, and that's the third ventricle. And around that, this is the basal ganglia and thalamus. This is the entire BGT complex. The deep gray matter is there. You can see the increased echogenicity, the whiteness. Whichever you see the whiteness, that's the increased echogenicity which is coming. So this will be a thing which you will look for. So entire basal ganglia. So this one also, this child, you can see increased echogenicity happening, and this child as well. The same thing you'll see in the cranial ultrasound scan, but you can't completely confirm it, although you have a heightened awareness that this child might have problem. Then get an MRI and you look for. These are all T1 weighted images, so that's why the CSF will look black. In T2, the CSF will look white. That is the difference between T1 and T2. So this is all T1 weighted images. So that is what you're looking for. So increased. So if you see such things, increased echogenicity in the basal ganglia and thalamus region, then you are fairly sure that this child will have some form of long-term outcome, and you should start working on this child as quickly as possible. So that is number one. The second thing which you look for is something called as the plick sign, which is basically the posterior limb of internal capsule. So this is the internal capsule, and this is the posterior limb. Usually internal capsule runs from there. That is the anterior limb, and this is the posterior limb. And in HIE, you will see the posterior limb of internal capsule, which will show echogenicity. So if you see this echogenic signal coming from the posterior limb of internal capsule, then you know this child also has got HIE, changes of HIE, and this child will be at high risk. Now, if you look at the prognostication markers, so normally this is what we'll say: BGT lesions give rise to cerebral, especially the athetoid type of cerebral palsy typically occurs with BGT lesions. So the child you saw here, these clear BGT lesions, then conventionally number one, you will say they can give rise to cerebral palsy. Okay. And again, BGT lesions can be graded by mild, moderate, and severe, but you don't need to worry about this because the radiologist will give you the report what it is. From your point of view, you definitely see that there is a BGT lesion, and the severity of the BGT lesion dictates the severity of impairment. So if they give it's a severe BGT lesion, obviously you'll say it's a long-term outcome will be bad. So this is the conventional thing. Look for BGT lesions. That is number one. The second thing, as I showed, is the plick sign, posterior limb of internal capsule. If you have plick sign, then you will have abnormal outcome, and the sensitivity of this is almost like 90%, and specificity is 10%. So here again, if you see a plick sign, then you are fairly sure that this child will have some form of motor outcome, motor delay. So again, this child you'll have to go towards sending for physiotherapy or occupational therapy. You start putting this child into that. So you look for two things in MRI. One is the BGT lesions, okay, and the second one is the plick sign. So if you do these two in MRI, then you are almost sorted. So, but you'll get an official report, but you can do it yourself, these two things. Now, the last thing is called as the MRS. Now, magnetic resonance spectroscopy. This is a new tool which has come in many institutes, and it is very helpful. And I'll just tell you how it works. So now you can see here, this is a normal brain. You can see the sulci and gyri. There is no increased lesion coming from the BGT area. That looks fine. This is a T2 weighted image because now you can see the CSF in the ventricle is white. Whenever you see the CSF in white, that means this is a T2 weighted. The previous ones, if you remember, the CSF were black. Yeah, the CSF is all black. So this is T1 weighted images. And this one is a T2 weighted image because you have the CSF which is white in color. Now what in the MRS they do is that you take a voxel. This is like a part of the brain which you put a signal intensity, and you want to look at what are the metabolites, what is the metabolic activity in that particular region. There are four prominent metabolites we want to look at the concentration. One is called as the choline, one is the creatinine, the third one is NAA, and the fourth one is lactate. Choline and creatinine, not many people use it, so I've not seen much, you think, but choline is a marker of membrane turnover, creatinine is marker of energy metabolism. So for all practical purpose, you can ignore them. The two main things which you need to focus is called as N-acetyl aspartate, that is the NAA, and the second one is lactate. Whenever you have a peak in N-acetyl aspartate, that means the neuronal integrity is maintained. Okay. If there is a damage to the neuronal integrity, the neural integrity is breached, then the NAA levels will fall. So that is what you look for. So if the NAA level is high, that means the neuronal integrity is fine. That means there is no damage to the neuron. That means no HIE. So that's what you look for. And you look for lactate levels. And lactate will have an anaerobic glycolysis. So hypoxia, which means there will be anaerobic metabolism. As a result, the lactate level will increase. So the normal is NAA is tall, lactate is low. If you see them reversing, lactate is high, NAA is low, that means that is a good marker for you to think for HIE. So again, T2, this is a T2 weighted image, this is a T1 weighted image. You can see the CSF is white here, CSF is black here. And both don't have a major BGT lesions. The BGT is looking good, both of them. And maybe here you can say with eye of faith that this BGT is looking a little bit white compared to this. So when you do a NA level, this is a normal thing. When you can see a NA lactate level, NA is high, lactate is low. So this is perfect. As I told here, maybe a little bit of increased echogenicity happening in the BGT area. So that is there. And then now you look at the NA and lactate level. The NA level is coming down and the lactate level is going up. Okay. So this will make you worry. Okay, I'm seeing some increased echogenicity on the BGT lesion, although I don't see any plic sign here, but the NA level is coming down, lactate level is going up. This one I will think about as a HIE. It can be moderate or severe. You can decide on that. But typically what we say in moderate, according to this, is the lactate NA levels will start coming down, lactate will go up. It won't reverse. In moderate, it won't reverse. In severe, lactate will be low. NA will be low, lactate will be high. That is severe. Okay. So this is the rough guidance. So you can look at this image that will help you out. Okay. So these are the things. Now, this is the paper which we published. That's me here. So this article we published in the Lancet from the Imperial College London. This is on 2018 when we published, and this is called as the Marble study. Okay, Marble study. So magnetic resonance. Again, all of us are using for the MRS, but you're looking at the outcome in encephalic children. Marble study, and what we found in this study was how can you start using markers to predict the long-term outcome. Okay. So we started with the number one, the most commonest thing which everyone uses is the clinical assessment, which is what we all used to, and that's what I've been telling. So the first thing which I told you was the neurological examination. I've told you about the NICHD tool, how to use it. People also have been using Sarnard score. People have been using the Thompson score and stuff like that. Sensitivity is about 42% and specificity is 94%. So in that way, it is fairly good. Likelihood ratio is also reasonably good. So if you see the area under the curve, which is basically what we call as the ROC curve. ROC curves are basically when you want to look for at what point with the test will be helpful. Say for example, when you see CRP, CRP of 10 and above increases, there's a good chance of infection. A CRP of 10 and below, perhaps not, because how did the number 10 come from? They plot it on the ROC curve. At what point where it will give you a true positive and also at the same time get away from the true negatives. So 10 was what we found the cutoff criteria. So similarly, your bilirubin levels. At what point where you want to start treatment at this point? Why not at, because technically jaundice, if you see adult level is only 1. Even a jaundice of 2 or 3 is abnormal. Why don't you start treatment at level of 2 or 3? Why do you wait until 12, 14? They all have come from ROC curves. So this is here the ROC curve, 0.72 from the clinical assessment. It is 72% okay to predict the long-term outcome. So you have to use every tool. Don't discard everything. Use everything in combination. So neurological examination, this is the first 6 hours of birth, which is NICHD. Discharge neurological examination. This is the HNNE. So this is the NICHD. This is the HNNE. So HNNE, when again 60% is the thing. So again, if you look at the long-term outcomes, it's coming more on the left-hand side. Then looking at the CFM. CFM is cerebral function monitoring. I'll talk a little bit more about that next. And it has got about 73% at the cutoff, where you can predict fairly surely that this child will have some form of long-term outcomes. Then we look at the conventional MRI, which is what I told. The cortex is basically looking at the watershed area lesions and 67%. BGT lesions. BGT lesions are the classical for the HIE. And then you have a high sensitivity, high specificity as well. And then it's about 0.81 under the ROC curve. So this is fairly good. Of all the things so far, BGT lesions go up to 0.81. Then we talked about the plic scoring. Plic scoring again 0.82%, going up more higher than the conventional thing. Diffusion MRI not much used nowadays, so fractional anisotropy not much used. So I don't see many people reporting that in the thing, but it's very helpful. As you can see, like 0.9% nowadays. If your radiologist can give you diffusion fractional anisotropy, then that will be good. But I don't see many people are giving this nowadays. The last comes the MR spectroscopy. And as I told, the main thing which you look for here is the lactate NAA concentration and the pure NAA concentration. Just the last two. If you see the lactate NAA concentration, if they are reversed, then 94% chance. And then if you see just the NAA concentration is completely going down, almost 99% fairly sure that you can predict. So at this point of time, if you have gone through all these things. In fact, we have gone through all these things. CFM, I'll talk a little bit more, but you know clinical assessment, you will know soon about CFM, you know the MRI, what to look for, BGT, Plick-Skine, and the watershed areas, and I've told you about the MRS. So these are the things. Ultrasound does not even feature here. As I told, ultrasound is just a screener tool. You can't use the long-term outcome prediction on that. That's the reason why it won't come on that. So the best marker at this point of time is the MRS, looking for the lactate and the NAA concentration. That is the best thing. And after below that, then comes the conventional MRI, which is looking at the basal ganglia and the Plick score. But don't forget, these are the simple things which you can do, clinical examination and stuff like that. Okay. Right. And that is the MRIs which I wanted to cover. Any questions on the MRI before I move to the next topic, which is the CFM? Okay, if there are no questions, then the last topic which I'll try to cover today is the CFM. Now, cerebral function monitoring is like an EEG, but you can't be doing EEG every time in the NICU. So what you do is that you use the amplitude integrated enhanced EEG. That is what we're trying to do. You need to apply only about 3 leads when you want to do this CFM. If you have 5 lead CFM also, it's good. So one will be in the center, which is the ground lead. Then you will put 2 on the frontal. That will be fine. If you have 2 more, then 2 on the parietal. So that's all. So very easy to put it. It has a needle. You just need to prick it in and apply gel. That's it. And it will start giving you the traces. So I don't know how many of you have ever used CFM, but it's a very good tool to start predicting long-term outcomes with CFM. And because by the time you wait for EEG and stuff like that, it takes a long time. And sometimes, you know, you will always worry, is this seizure? Is it not a seizure? You don't know. But here, every answer is given straight away. Okay. So in terms of classification, the main thing which you need to look for, this is how the CFM will look like. Okay, I'll show you some more examples how the CFM will look like, but this is what the CFM will look like. So in the normal EEG, you will be getting a single wave trace. Here, because it's an integrated EEG, the entire EEG, what you'll be seeing almost like 30 seconds is getting compressed to 1 minute. So that's why you will see a big broad trace. So what you're looking for is a normal trace here. A normal trace is very simple. You imagine this CFM going through. In a normal trace, the lower margin is above 5. Can you see here 0, 5, 10, 25, 100? So that is 5. Okay. In the normal trace, the lower margin. So this is the lower margin in all the way it is going through. So the lower margin will always be above 5. So this is 5 and the lower margin is well above 5. And the upper margin is above 10. So this is the upper margin. And the upper margin is also above 10. So whenever you see a CFM trace above 5, above 10, then it is completely normal. Okay. You will see this variation. It's a small band here and suddenly a band becomes big here. And then again, this is called as a sleep-wake cycling. It's written sleep-wake. So when the child is sleeping, then your activity in the brain reduces. As a result, the voltage falls. Okay. So as a result, the thing becomes bigger. And the child is active, then the brain is much more active. So your voltage rises. So this is the sleep-wake cycling, and it's a very important marker. As you see sleep-wake cycling, that means the child is getting better in the HIE children. Okay. So this is the normal pattern. Now in moderately abnormal, the lower thing first always drops. Then the top will fall. So the lower thing will fall. So lower thing is below 5, upper margin is still above 10. So if you can see here, this is 5, and you can see the lower margin is sometimes going below 5. Yeah, and this one you can see the lower margin is below 5. This is 1, and then upper margin has to be above 10. So this is 10. You can see the upper margin is still above 10 here, and here the upper margin is above 10. So you will get a broad band. So whenever you see a broad band, then that is moderate. Okay. In normal, you get a small band. In severe, also you get a small band. Only difference is that in the normal, the broad band, the severe, the band is well above 5 and 10, and in severe, the band is well below 5 and 10. That's all. Moderate is very easy to identify. You get a broad band. Okay, so that is moderate. And in severe, everything will fall down. So less than 5, less than 10. This is all above 5, above 10. Here, less than 5, above 10. So it's because it has to give a broad band. Here, below 5, below 10. So you can see here, this trace is completely below 5, below 10. This one also below 5 and below 10. Whenever you see this is a flat trace, this is what we'll call as the severe arm. So this is very easy to classify the CFM. Just remember 5 and 10. There are other ways of classification that is called as continuous normal voltage. I don't need to worry about these things. Nobody uses that one. But these are all certain patterns. If you say normal, moderately, and severe abnormal, you are done. People will also call patterns. So this one you see burst suppression. What is burst suppression? A burst of activity followed by suppressed. Burst of activity followed by suppressed. So that is called burst suppression. But it is basically a part of the moderate because you're getting a big band. It's a moderate band. Low voltage, that means completely fallen down. You don't see anything. And something called as a flat trace or isoelectric. There is no activity. Occasionally, one activity here. This is the severe form. Okay, but this is what some people will say, no, burst suppression activity, low voltage activity, flat trace. What is burst suppression? Then you know. This is a burst of activity followed by suppression. So this is the CFM. And what I'll do is I'll show you some more examples of CFM, which we have. So ideally, I do it as a quiz. So I ask quiz for people, tell me what do you think is the, but we have only 4 people here. So there's not much to do a quiz. So a simple look at this. This is 5 is here. So most of the lower margin is running above 5. So that's good. And 10 is here. The upper margin is running above 10. So you will say this is normal. And occasionally, maybe here, because it's a small band, but maybe here suddenly it becomes a bit big. Maybe a little bit of sleep-wake cycling, but not as convincing as the first one. So I'll pass it as a normal EEG, normal CFM in this. There's nothing to worry. Now, clearly, you see, 5 is there, 10 is there. So the lower margin is well below 5. So it is going there. And 10 is the margin here. If you clearly see, maybe some of them are touching 10. So a little bit of broadband is coming here. Initial bit, you will probably see it's below 10. So it's a bit of severe suppression here. But as time goes, slightly you're seeing some amount of moderate band. And when you come here, it is becoming a bit more moderate. So this child was initially severely suppressed. And as time went, he became moderate because you can see above 5, below 5, but above 10, you will see a moderate band here. So you will say initial part is severely suppressed until this point. And after that, he's got better. He's gone into moderate. Now, again, below 5, so completely below 5 here, and below 10, because the upper end of margin is still here. Occasionally, this child has spike. So these are all the spikes. These spikes are because of seizures. Okay, because see at the same time you can see the single trace. You can see multiple B's here. So these are all the spikes. So this child has got a very flat CFM below 5, below 10, but occasionally this child is having multiple seizures, and as a result, the trace is going up. So you will classify this as a severe suppression, but it has got a lot of seizures, and you will be starting treating this child. Now, big band, whenever you see big band, this is a moderate thing because it is below 5 and above 10. So it's a moderate CFM. But that's all, nothing else more you can take about that. Maybe occasional sleep-wake cycling, but it's a moderate CFM. Now, this one will be what we call as multiple seizures. These are all seizure. Okay. So the same thing, you'll confirm it on the normal EEG. Multiple spikes is seizures. But if you see here, it's above 5, above 10. So it looks like as if it's a normal trace. But I suspect this EEG has not been put properly. So as a result, the traces have all shifted up. But this is not a normal trace, because if you see so many seizures, this child has to be severely suppressed to have so many seizures. Again, this is whenever you see single spike, and here also multiple spikes. So this is a seizure. There is no doubt about that. And this one looks okay. It's just above 5, above 10, normal activity, nothing major. Looks good here. And again, big bands. The moment you see big bands, it is moderate. So you can say this is moderately CFM. No issues there, and maybe somewhere here you lost the trace. That's all. It's not a seizure because you don't see any spikes in the EEG, so it's not a seizure. Again, big bands, so this is a moderately abnormal CFM. Nothing to worry here. And this one here above 5, above 10, so this will be probably a normal amplitude EEG. There's nothing to worry here. This is severely suppressed, below 5, below 10, and some seizures. Everywhere seizures. You will be putting it as seizures. Okay, I think that's pretty much what I wanted to show you in terms of CFM. So let me go back to the previous presentation. So CFM is very easy. Now, what are the predictors of CFM? How can you predict the long-term outcome using CFM? The moment you see seizure, that means this child has had a moderate to severe HIE. So seizures come in moderate to severe HIE. So the moment you see this occurrence of seizures, especially in the first 12 hours of life, that means the child has had severe, HIE, so that the child is triggering. Then, and especially if you can't control, then this child will have adverse outcome. So again, for you, there is no doubts in that one, that a child having seizures, moderate to severe, and if you're not able to control the seizure occurring within 12 hours, then you fairly sure that this child will have adverse outcome. This child should be on your regular follow-up. Now, I told you about the severe background abnormalities. One is the burst suppression, so completely suppressed, and then burst. Isoelectricity is the flat line, which I showed you. Poor voltage, I also showed you that one as well. So isoelectricity is same as the flat trace. These are all signifying that means there's no major activity happening in the brain. So clearly you can thinking about death is quite high in this child, or significant long-term neuron. So whenever you see severe patterns, flat trace, low voltage, seizures, then not seizures, but actually probably flat trace and the burst suppression, then you know that this child, the chances of death is very high, and if the child survives, the significant long-term neurological age. So such an EEG, whenever you see in moderate or severe encephalopathy, and if it stays for more than 2 days, flat trace for 2 days or something, then clearly you can say the death is quite high. And if the death is still there, then you will have a long-term outcome, and at 1 year, this child will have some amount of issues there. Last one, if you see a normal background within 18 to 24 hours, that is basically the child who might have had a moderately abnormal or severe, but as time goes, you're doing cooling or something, the child is moving towards a normal background within 18 to 24 hours. Then you think that CFM is getting better. Then also, if you start seeing sleep-wake cycling within 36 hours, then the child will have a very good outcome. So these are all the predictors of a good outcome. So if you see normal background within 18 to 24 hours, if you start seeing sleep-wake cycling within 36 hours, and an EEG which shows persistent severe background abnormality, which I told you earlier, then that will have a bad outcome. But return of sleep-wake cycling within 36 hours is considered as one of the very good outcome in HIE. And if you see this happening, then you're fairly sure that the child will have a good outcome. Right. And the last bit which I want to tell you is that, which is not with you, but make sure you get these done. That is basically the eye assessment and the audiology assessment. We have some additional noise.
I think development of new noises have been noticed.
Okay, so you can mute them. That's all. Okay, fine. So ophthalmology and audiology assessment is straightforward. You need to get it done as a part of your HIE assessment, because sometimes this is sometimes slightly neglected because it's not a part of the NICU, but people suddenly forget to do these things. I always try to remind them that any HIE and stuff, make sure, because if you don't have any visual input for this child, how would you expect development? Similarly, if there is no auditory input for the child, how you expect development? So make sure all these HIE children, you will need to do, or any child who comes with some neurodevelopment delay, respect to whatever parents tell, I would just get at least one hearing test, which can be otoacoustic emission. OA is most common, or if not, the child is 3 or 4 months and you can do a BERA test, then get a BERA done. And similarly for eyes, you can get a proper assessment to just rule out cataracts, or in preterm cases, if there is a ROP and stuff like that. So you need to rule it out. So do these two things as a part of the routine assessment for any child who comes with developmental delay. Okay, so that's pretty much what I wanted to cover today. And any questions before the next section onwards, we'll just move to the long-term neurodevelopmental assessment. If you have any questions, please feel free to ask me. But otherwise, we have so far covered the clinical predictors, which is using the chart while classifying as mild, moderate, and severe. Then the second assessment, we've talked about the neurological examination. That's at the birth and then at the time of discharge. Then we talked about the lab parameters last time, about the glucose, jaundice, thyroid function test, cord blood, gases, and all those things. Today, we talked about the ultrasound scan, and I would recommend you all to do an ultrasound course, which is very helpful, and it's something which is a tool which you can do bedside. Then I've told you about how to read an MRI, simple things, especially for HIE, and I've showed you CFM. And having CFM is such a life changer, game changer, because you can start predicting so many things just on the neonatal unit and get a ophthalmology and audiology assessment. So I've covered 4 major sections so far. And then the next 2 sections will be on neurodevelopmental outcomes. So I'll be in the next 2 sections, I'll cover about the dailies. I'll cover about DDST. Then I'll look into briefly into autism and ADHD. So that should take us for the next 2 to 3 sessions. And then the final session will be the revision session, which we'll do after a month or so. So if you have any questions, please feel free to ask me.
Any one of you can post any of your question in the chat, and if it is not happening, then within 1 minute we're going to close the session. And like Sir has said, you can even post your questions later on in the group, which and I will be after permission I'll be I'll be adding Dr. Ravi sir on the group, so that wherever we discuss about the development issues, the opinion can also be given by sir as well. Right, boss?
Yeah.
I think there are no questions, sir. We can close the session. Yeah.
Yeah. Okay.
Thank
you,
you
everyone. Thank you.
Yeah.
Bye.
Thank you.